actually allowed to do. We're going to talk about medical legal things, what we're able to do within the confines of the law, because in the event of medical emergencies, sometimes we are going to be taking people to the hospital when they say they don't want to go. And we're going to talk about when that's acceptable, when it's not. And then the latter part of tonight, we're actually going to start looking at some of these emergencies. You know, like last week, we did a little bit of learning, then we talked about anaphylaxis and the medications we'd use there. And then this week, we're going to talk about some altered mental status, things that can make people act strangely. And that's kind of why I wanted to pair that with medical legal, because they oftentimes go together. So right when we start, I do have a disclaimer here. Later in the video, in the lecture, I am going to show you some videos of real-world situations. They are sometimes hard to watch. We are going to be talking about things like opiate drug use today, so we are going to be seeing some evidence of that as well. I just wanted to give you a heads up, and as we get closer, you'll see why I'm showing them to you. Again, the only reason I put this up here is just so you're aware of what I'm going to show you, and then also so that you know I'm not trying to glorify anything that I'm showing you. I'm showing you all these videos for educational purposes, and I definitely don't condone like the idea of making fun of people in these situations. Now, before we begin, I have a quick question for you. Do you see the minnow fin? If you did, you might say something along the lines of, yes, I see the minnow fin. Thank you. Bad joke, right? We're going to be talking about some medications tonight, so I like to include that as well. Now, when we talk about assessments, it's not good enough to just call it one thing. We're going to have to assess a lot of different things at a lot of different points and a lot of different times. So we use assessments on every single call. Whether it's me arriving on the scene of a car accident, and me using my eyes, my ears, all of my senses to kind of take a look at what's happening. Do I see anything dangerous for me? Do I see anybody who's hurt? To a more one-on-one assessment where I'm responding to a direct issue. Somebody says, I'm having difficulty breathing, and we show up, we take vital signs, and we ask this person really what's going on, and we try to get to the bottom of it. So we become something when we arrive on a call. If you are arriving as a medical first responder, we become something that I like to call like a medical detective. Our job is to figure out what happened, how it affects our patient, and what we're able to do about it. And anything outside of those confounds, we're just going to bring them to the hospital or call the correct people who can help. So we need to get really good at using our knowledge, using our assessment tools to figure out how severe something is quickly so we can know what our best course of action is. And that's what makes us good medical detectives. Now, the first thing that we are always going to worry about before we arrive on an emergency scene is safety. All right, this is the most important thing for us. If it's not safe for us to begin helping somebody because we could get hurt or injured ourselves, then we're not going to go into that scene. That's one of the challenging parts about this job. It's like, hey, if somebody's actively hurt, but there's something that will stop us from going on scene, whether it be an environmental issue like a fire in the area, or a personal issue like somebody who's hurting people, right? We're not going to go and get ourselves hurt because our priorities need to be ourselves, our crew, and then our patient. The way that I like to think about this is an ambulance can take on a good day, and depending on the situation, take around 2 people up to the hospital at one time, 2 patients. That's with a full crew, and that's with not severe injuries. We're only really going to take 1 severe patient up to the hospital in an ambulance at a time if we can, and maybe 2 moderate level, right? So if we show up to a scene that has 3 patients at it, that means we need more than 1 ambulance. We're going to need at least 1 more. If one of us goes onto that scene and becomes hurt because we didn't do a good assessment, or we were trying to be a hero, or we just didn't take the time it took to do a good assessment, and now we become hurt, there are 4 patients on that scene now. And your crew who's with you, who is staffing one of those ambulances, is no longer going to be able to worry about staffing an ambulance. They're going to be worrying about taking care of you until the other ambulances arrive, putting themselves in danger too, meaning 2 more ambulances, right? So it is just doesn't make sense for us to become hurt on a scene. We're going to just double and triple the amount of people and resources needed to manage this scene. So we always need to make sure it is safe. If we are on a scene that we have determined to be safe and it becomes unsafe, we need to leave. Even if that means the patient we were treating will end up worse for wear. So this is a tough situation. But let's start talking about it a little bit more. Take a look at this picture, right? Let's say that you got called to a scene and this is what you saw when you showed up. What are the parts about it that make you say it's unsafe? What are some things that make you think it might be safe? All right, electricity and water make it unsafe. Wet ground, live wires. Yeah, absolutely. This is the biggest part here. We can see downed telephone pole. Lots of electrical current going through here. We can see the transformer on the ground. That was obviously damaged. The scene is wet too. Electricity and water definitely do not mix in a safe way for us. So right away, if we showed up and we saw a car resting right underneath here with somebody who needed medical attention, it's not safe for us to immediately run over and start giving care. We need to call the fire department, who is probably going to call power, and they're going to disconnect the power or at least make it safe for us to actually go and start helping that patient. But if you just ran over and you started treating this person without a care of what's going on around you, you could be killed from this electricity, right? It's not something we joke around with. Scene safety is very important. You can also tell that the fire department has been here because there is some oil on the ground that has a coating to it. They've put some sand or sawdust on top of it to try to soak up some of that material. Flammable material, right? So it's very important for us to do a good scene assessment and make sure it's safe before we can show up. What about this one? This is a relatively common thing that happens in EMS. Car accidents. Us responding to something on the side of the road. Is this a safe or an unsafe scene? Lots of good things. Traffic is unsafe. The rain and all the traffic aren't ideal. The engine could be leaking oil. Yeah, all really good thoughts. I actually really like the idea that it's not ideal, right? It's not necessarily unsafe. It's just not where we would prefer to be. We are going to have to manage scenes like this on the sides of the roads. That's where these emergencies happen. But where we do it, how we do it is where it's important. Recognizing that it is not ideal and it's not the safest situation means that we're going to have to do some other things. So we might be on the side of the road near active traffic while we manage emergencies, but we always wear reflective vests. We should always be having like markers, or our ambulance should be set up in a way where it's blocking traffic. So this is actually like after the scene. So the patient is gone. You would see more fire trucks and probably an ambulance parked down here. They'd be trying to block the scene so that cars wouldn't hit us. So there's a lot of steps we're going to need to take before it becomes safe. So good on you for recognizing, hey, you know what? It's kind of safe, but it's not ideal. That's exactly where I was going with this. All right, and now what about this one? Pretty obvious, I'd have to say. Lots of oil, lots of fluids. Yep, we don't know what this is. It could be like windshield wiper fluid, or it could be gasoline. That definitely looks like oil, very slick, flammable, so we need to be extra cautious. Now here's another thing about scene size up that I want to point out to you. We've got two cars, head-on collision. How many patients do you think we have at this scene? Why do you say 3, Zen? Or at least 2, Kiara? Just getting the clarification on some of the answers. It all makes sense, right? Somebody has to be driving at least one car. So at very minimum, 2. Yeah, we also don't know, was one car parked? Now here's the other challenge. How many patients maximum could there be? If each car sits 7, maybe a little less, maybe 5, maximum of 10 patients. Now, how many of you have ever ridden in a car with some friends without your own seat? Oh, this is recording. I didn't do that, right? So that's the other thing. We can't just necessarily assume we know exactly how many patients we're arriving to. So you might show up, do an assessment, see one person standing by this car, and be like, oh, yeah, we just got one person. And then you arrive and they point to a row of like 12 people who they had shoved in their car because they were going to a party and they didn't want to wait for another car, right? That means we're going to need to call more ambulances because we can't transport 12 people in one. So not only is there a scene safety issue for us, but we also need to start thinking about how many patients are there. Just because we're responding to a car crash doesn't mean there's just one or there's just 2. There might be 10. Is it a school bus? Is it a city bus, right? We need to start thinking about that. Before we can actually start treating our patients, we need to have the appropriate amount of resources. We need to make sure it's safe, and we need to make sure help is on the way. Now, when we actually start treating our patients, we do have to continually assess for safety. We might be responding to somebody who is ill, who has a communicable disease. Hey, remember we talked about it last week? COVID happened, and that threw EMS on its head. We used to only really wear gloves, masks, and glasses, really when somebody needed it. I always wore gloves on calls, but it was only when we were told to wear a mask or we suspected that we should that we'd put one on. Now, basically, anytime somebody has a cough or difficulty breathing, we're going to throw one on just in case, right? So this is a huge part about protecting ourselves as well. Every time you go on a call, anytime you're going to touch a patient, you should be doing it with gloved hands. It's not because we're just going to assume they're gross. We just are just going to make sure that we're protecting ourselves no matter what. You're going to go through a whole bunch of gloves. You're going to need them. You should be wearing gloves anytime you touch a patient. This is us practicing something called BSI, so body substance isolation. And essentially, we're just going to keep all body substances away from us as much as possible. Do we wear gowns if it's still a COVID patient? I don't think we're doing full gown ups. I'm pretty sure it's just going to be a good N95 mask with gloves. I'm pretty sure that's what we're sticking to. We do carry full personal protective equipment sets on the ambulance, like full gowns, face shields, booties, everything you'd need. But we're not going to be totally gowning up for a COVID patient anymore. We've proven that N95 masks, gloves, and the normal protectants will work. You don't need a gown for it. Really, when we need gowns is when somebody is covered in a substance like a bodily fluid, whether it's blood, poop, gross things like that. If somebody is completely covered, you're going to want to protect yourself as much as possible. But for, I'd say 75% of calls, a pair of gloves is always what you're going to need. You should always be wearing gloves. That's basically the minimum. The rule I like to stick to for BSI is if it's icky, sticky, ooey gooey, and not yours, just don't touch it, right? There's no need to play with anything that's gross. You might need to touch gross things, but if you don't need to, then there's no reason to, all right? Just leave it over there. But now that we've protected ourselves, we've assessed the scene, we've seen how many patients there are, what other resources we're going to need, and we've put our protective gear on. Now we're actually going to lay our eyes on the patient. And this is where we're going to start having some of those thoughts about what we need to ask them, what we need to focus on in our brain. So these are our first things we want to worry about. When I first lay my eyes on the patient, these are the questions I have, and these are what I'm looking for, because any of these being off or abnormal is really going to tell us that that patient is sick. So first things first, what we do naturally is we use our eyes, and we're probably going to see our patient before we start talking to them. And that's when we're going to get something called a general impression. Now, I mentioned this last week, right? Your entire life, you've been taught, and you should still continue to do this, that in your day-to-day life, you should not judge people based off of how they look. In EMS, you will have to do that a little bit, and it's for their benefit. Just by looking at a patient using our eyes, we can get a really good idea of how sick or not sick they are. Let's take a look at this guy, right? Just from looking at this picture, is this guy having a good time or is he not? And what's going on with him? Yeah, I would say the same thing, right? Just by looking at a snapshot of this guy, he's having trouble breathing. He's leaning forward. He's got pursed lips. His face looks like he's a little bit intense, right? He's focusing on something. And there is also an inhaler resting right on the table. All right, so even with just a snapshot, just by you looking at this person, you can say, oh, my general impression of this guy is that he's having difficulty breathing, right? But if you showed up and he's sitting in the chair, he's got his leg kicked up, his arms crossed, and you walk in and you're like, hey, what's going on? And you're like, hey, man, I'm having difficulty breathing. I'd be like, are you really? Okay, why don't you describe to me what's going on? But for this guy, I'd say, hey, are you having trouble breathing? Right? So use that general impression. Look at these things that can help tell you how sick somebody is going to be. So after we've done our general impression, now we're actually going to start talking to the person. We want to gain their level of consciousness. Essentially, this means, are they going to be able to answer our questions? Right? Are they alert? What is it like? Alert is a little bit different than oriented, right? So alert means when they can just open their eyes spontaneously and they respond to stimulus. So if somebody talks to you, the natural thing that you're going to do is go, huh? Right? They speak to you, you're going to look at them and you're going to speak back. That means you're alert. If somebody doesn't do that, that tells us something's out of the ordinary. Right? If they're kind of dozing off in their chair, and even if you tap on them, they go, but then they open their eyes and they don't seem to look at you. That means they're not alert, right? And then oriented, this means I know where I am. I know what's going on. So if you didn't know who I was or what I was doing right now, and you asked me, what's your name? What are you doing right now? Where are you? And what time of day is it? Basically, everybody will be able to answer those questions at any given time. Right? You should know those things. My name is Kevin. I'm giving a Zoom lecture. I'm in South Burlington, and it's roughly, 6 o'clock. 10 minutes off, not a big deal, but I'm of sound mind. I know who I am, I know where I am, and I know what's going on. If you came to my house and I said, oh, my name is Sir Lancelot, I'm in Camelot, and it's roughly 1495 AD, right? And my chest is hurting. I'd be like, hey man, great. Let's get you to the hospital. Something is wrong, right? Or if I'm just completely unresponsive and I don't say anything at all, but I'm still breathing and I won't wake up no matter what you do, that is also abnormal. So we want to gain their level of alertness, their level of orientation, their level of consciousness. And then after that, we want to focus on those 3 areas that matter to our life, right? The airway, the breathing, and the circulation. Now, we can get those things pretty quickly from somebody who's awake. If they just answer us, if you say, hey, what's your name, buddy? And I go, my name is Kevin, you know that I have a clear airway because you can hear me speaking. You know that I'm breathing because you can hear me speaking. And I'm not going, right? And then you know I have a pulse by the fact that I'm speaking. And you can use the other assessment tools you have by looking at the condition of my skin. Do I look pale? Do I look sweaty? Do I look flushed and red? And you can also just verify by checking right here. Okay, yeah, his ABCs are all right. He's breathing, he has an open airway, and his pulse is still pulsing. And then from this assessment, just from this little bit of knowledge, this is where we're going to get that gut feeling. Is this person sick or are they not sick? And another clarification I want to make is that when we say the word sick in EMS, I'm not talking about has a cold. Right? I'm not going to show up and somebody be like, yeah, I took some NyQuil, right? I got allergies. I'm not going to be like, oh, you're sick. You need to go to the hospital. I'm going to say, oh, yeah, take your medication, right? In EMS, I mean, sick is going to die in the next hour to 2, or not sick, not going to die in the next hour to 2. So that's what I mean. And trust me, when you speak to somebody, if you just do this general impression and they're not doing well, you're going to say, oh boy, they're sick. Let's get going. Versus, you know what? You're not sick. We can still bring you to the hospital, but I'm not going to rush. That's our goal. How quickly do we need to get them to where they're going? So let's do a little bit more work with this general impression. I'm going to show you two pictures, and I just want you to give me an idea, just from looking at them pretty briefly, sick or not sick. All right, here you go. Sick or not sick? Why? Why is he not sick? He's on oxygen. Yeah. No, you're absolutely right. Sure. He's on oxygen. I found this picture specifically because to try to throw you off. But he's smiling. He doesn't look pale or sweaty. He just looks like an elderly dude who might need some help, right? To me, he probably has a chronic condition. There's a reason he's on home oxygen. He might need to get checked up. He might have a small something going on with his oxygen or whatever. But just by looking at him, I don't think he's sick. Sure, he has a chronic illness. He needs to take medications. But yeah, I don't think he's going to die in the next couple hours, right? What do you say about this guy? Yeah, sick. Not like sick, right? But he's not looking good. He is pale. He is sweaty. He's got bags under his eyes, right? His facial expression tells you, yeah, he looks sickly. He looks gaunt. He does not look happy. You cannot lie. Your skin cannot lie. Your skin is so heavily connected to our circulatory system. You can't fake being sweaty, and you can't fake being pale and sickly colored, right? So if you look at somebody and you see the signs that something is going on in their body, follow it. Listen to your gut, right? Use that first gut feeling, do your assessments to follow, and then take it where it goes from there. But this first assessment, this first gut feeling can take you a long way. So now, I'll be honest, we're getting into a few acronyms. All right, this is the annoying part about EMS, the things that we have to remember to the point that we can just recall them whenever we need them. So we are going to be doing a couple of those things. So just so you are aware, acronyms will help you. They're annoying, but they will help. All right. This is the first acronym. It is about that level of consciousness. And essentially how this acronym works is we're going to work our way down it. And essentially we're going to stop and give this patient whatever letter they're at when we've assessed it. All right. So alert is just where we're hoping to be. That means somebody is just sitting there awake, looking around, responding to you as you speak to them. That's about it. It is what you'd expect for most human beings. So if I arrive and I look at somebody, they're sitting in a chair, and I say, hey, how you doing? They go, not too great. I called 911. I'm going to say they're alert, right? I'm going to stop right there. If I show up and they look to be asleep, right? Their eyes are closed. But when I say, hey, how you doing? They open their eyes, and maybe they go back to it, but they always open their eyes and they make a noise when I speak to them loudly or I just speak to them. That means they're responsive to verbal. Right? Somebody who is asleep is typically responsive to verbal, and then they will become alert right after we wake them up. But responsive to verbal only means just like somebody's going in and out. You have to keep keeping them awake, and if you speak to them, they'll open their eyes. More like this, right? You're like, and they go, hey, and you, huh? Yeah? That's somebody who's alert to verbal. Now, responsive to pain only, this is if we show up, somebody's on the ground, their eyes are closed, we say, hey, are you okay? They don't respond, and we give them like a couple pats on the shoulder. We say, hey, are you okay? And they still don't respond. Then we're actually going to elicit a tiny bit of pain from them. So what I mean is there are approved ways to do this. We're not just going to go like slap our patients or do whatever we want. What we're going to do is we can either do something called a sternum rub. So you're going to take your knuckles, your front knuckles, and you're going to rub them really hard on someone's sternum. That works pretty well. Or you can do a trapezius pinch. So you take your thumb and your middle finger and you try to connect them under that person's trapezius muscle, right? So you do that and you're looking at their face for any response to pain. If they're unresponsive and you give them a good squeeze and they go, right? That just tells us they're responsive to pain. If they don't respond to that painful stimulus, they're breathing, they have a pulse, but like you give them a good pinch or a good sternum rub and they don't make any movement at all or any response, that's bad, right? That just means they are unresponsive. So what we're actually doing here is we're going down their neurological assessment, their most baseline neurologic assessment. They should be alert. If they're not, can they hear us? If they can't, can they feel us? If not, that's bad, right? They should be able to do one of those things. So we're going to go through that and we're going to assess them. After that, we're going to go for that ABCs. Now, one of the challenging things here, or one of the differences, is that if somebody is awake, if somebody is alert, it's going to be pretty easy to assess these things. We just have to ask them a question, and they have to speak back. If they can speak to you, they have an open airway, they're breathing, and they probably have good circulation. But if they're unresponsive, we're going to have to do a little bit more hands-on assessment. So if they're not waking up, we're going to have to physically open their airway and look inside their mouth. We're going to have to look, listen, and feel to assess their breathing. We're going to look at their chest. We're going to put our ear right next to their mouth. We're going to feel for their breath. We're going to listen to their mouth, and we're going to look to see that chest rise and fall. And if they're unresponsive, we're going to have to check for a pulse. And we want to check right here on the carotid. So those are our first things. If we go, hey, are you okay? They don't respond to verbal. They don't respond to pain. My next step is I'm immediately going to open their mouth and look inside, open their airway. I'm going to check to make sure they're breathing, and I'm going to look to see how well they're breathing. And I'm also going to feel for their pulse and make sure they're not bleeding anywhere or that I can actually feel something. And this is going to tell us the most we need to know about our patient. This is really going to tell us sick or not sick. All right, but it's not good enough just to get presence. It's not good enough just to say, yes, they are breathing or yes, they have a pulse. We also need to assess for the quality. So what that means, right, is if I'm assessing somebody's breathing, if I see their chest rising and falling, I'm also looking for how well they're breathing. Is there any abnormal sounds? Do I hear snoring? Do I hear wheezing? Do I see a really fast breathing rate? Are they breathing like... Sure, they're breathing, but that doesn't seem very good to me. Or are they breathing too slowly? So it's not just about are they breathing, it's how well are they breathing. And then it's the same thing with the pulse too. Sure, I can feel the pulse at my fingers, but is it strong? Do I have to sit there and feel around for a little bit? When I feel it, does it feel really noticeable, or is it kind of in and out? Is it really weak? Is it really fast, or is it really slow? Right? Those are all things we're looking for too. Just to help tell us how sick this person is, because all of the injuries that will kill somebody really quickly are injuries or illnesses that affect these three things, the ABCs. Right? So we need to be thinking about these things as well. Not just good enough to say, do they have a pulse? Are they breathing? But how are they breathing? And how does their pulse feel? Once we've got the ABCs, this tells us that patient priority, right? Are they sick or are they not sick? Do we need to get them to the hospital ASAP? Or can we take our time? Or maybe we don't even need to transport this patient. Let's think about other ways that we can get them what they need. So what we do for our patient, how quickly we go, this is all going to depend on that gut feeling. Now, one thing I want to let you know is, especially at the VEFR and the EMT level, it is always better to treat somebody who is not having a severe emergency as severe than it is to ignore something and treat somebody who is sick as not sick. So because we are getting a limited amount of assessment tools, it's always better to treat somebody who you're not sure, who you have some confusions or concerns about, as a sick patient than not at all. When you show up to the hospital, they are still going to get what they need. And remember, this can change very quickly too. You might show up and say, wow, my patient is not sick. Hold on, sorry. Why are you doing this to me? There it goes. we might show up to somebody who is presenting as not sick, and then over time that we're with them, their designation changes. They become sick. So it's always okay to reevaluate this, and we are going to need to do that. We're going to need to be constantly assessing our patients. But still, we need to make sure we have a good gut feeling. All right. That's that first initial assessment. The general impression, the level of consciousness, and their airway, their breathing, and their circulation. What we need to work on now is some other acronyms to help us figure out what the patient's medical history is, and then also what the history of their present illness is. So the first one is SAMPLE, S-A-M-P-L-E. This is the history of the patient throughout their life, like their most important medical history. So besides just kind of asking a few questions about what's going on right now, like what do we see, what are the signs and symptoms, we also want to ask them things like, what are their allergies? Are they allergic to any medications? Are they allergic to foods, or really anything else? This can really change or impact their treatment. All of these allergies should be documented in their medical record, but we definitely need to double check, especially if we are thinking we might give them medications. Speaking of medications, our next in question is, do they take any? Oftentimes, we're going to be responding to people who might be taking quite a few medications. Like they have a whole novel full of their medical history with all the meds that they take. But we really want to know, right? Do you take daily meds? What are they for? And then have you been taking them? We don't necessarily need to be like 100% well-versed like a pharmacist level on a whole bunch of different medications. But if we say, what are your meds? We document those. What do you take them for? We document that. And then we say, have you been taking them? And they say no. We're going to say, great. That's probably the cause of your emergency, right? Let's bring you to the hospital. Figure it out. But that's only half of the medical history here. The next thing is, what is the pertinent past history? And we want to relate this to what they're experiencing right now, right? So if we show up to somebody who's having really bad crushing chest pain on the left side of their chest, and we say, what's your past medical history? What I don't want to hear about is I don't want to hear about the time that they broke their leg in 6th grade, or that they fell and got a scrape on their elbow in 9th grade, or that they had mono in college, right? I don't care about that. You're having crushing chest pain. Have you had a heart attack before? Has this ever happened to you before? If they say, yeah, I had a heart attack before and this feels exactly the same, I'm going to say, hey, wow, you're probably having a heart attack. Let's get you going to the hospital. But if they say, no, I've never had anything like this before, that just leads us down another, like, hey, that's good information for the hospital to know. So that's why it's past pertinent history. After that, we also want to know, when was the last thing they ate or drank? And essentially, forgot to add it on the slide, but it's last intakes and last outputs, right? When was the last time you had anything to drink? When was the last time you went to the bathroom? And was it all normal? We want to know about food that somebody's eaten, because if they're allergic to something in it, that could be the cause of the emergency. We also want to know because if they need emergent surgery, the hospital's going to need to know when the last meal was. And then also we need to know about bathroom habits, because if somebody is drinking like 2 gallons of water a day, but peeing twice a week, that's not good, right? If they're drinking 1 cup of water over 2 weeks and they're peeing 6 times a day, that's not good. Vice versa, right? So it's important for us to ask about those things. When was the last time you went? Was it normal? And then, of course, was there anything that happened before your emergency that may have led to it, right? Were you exercising really hard before you started having difficulty breathing? Or were you driving a car before you got in a car accident? Those types of things. All right, so that is sample. That is about the past medical history. Where this one, it's not nearly as satisfying. It's OPQRST. Doesn't have a fun word that it lines up with. But this is really important because this is all about the history of why they called 911 today. What is going on that made them so nervous? So we want to ask these questions. And while you're learning this acronym, it might feel weird to like try to talk to somebody and go through like an acronym to like ask them questions. But after a while, you'll realize that this is just a natural conversation that follows the line of medical reasoning. So I'm going to ask them, right? When did this start? Somebody said, I'm having chest pain, crushing chest pain that radiates. There you go. That's one of them. I say, when did it start? They say 30 minutes ago. That tells me, okay, relatively recent. But if they say 3 hours ago or 2 days ago, I'm going to say, why didn't you call sooner? Right? So when did it start? Kind of what were you doing? Provocation and palliation. So provocation means, what were you doing when it started? Was there anything that you did that makes it worse? Is there anything that you can do that makes it better? Somebody with chest pain says, it gets worse if I move, if I exert myself, or it gets better when I rest. That definitely leads me down the line of, hey, I think you're having a heart attack. Quality. This is, what does it feel like? Can you describe the pain for me? Now, this is a tricky one because we want to leave this open-ended. We don't want to give somebody options. If I look at somebody with chest pain and I say, describe what that pain feels like for me. Is it sharp or is it dull? That patient only has two options. They can either say sharp or dull. But if I say, hey, in your words, describe that pain for me, and they go, oh, it's kind of crushing. Feels like a weight on my chest. Feels really heavy, right? I let that patient describe it, and I'm going to get a much better understanding of what's going on. So when you ask this question, always leave it open-ended. Don't give them any options. Let them describe it themselves. Another good example of this is there's a specific emergency called a descending aortic aneurysm, essentially. A really big blood vessel in our body. If it ruptures, it can, people bleed out really quickly. And one of the weird things about it is it's one of the only emergent conditions that patients will routinely describe as tearing. And very few other emergencies are described as having a tearing feeling. So I'll tell you, if somebody, like, I responded to emergency and someone says, oh, I got this terrible tearing feeling in my back or my stomach, I'm going to go, oh, crap, right? That's a very rare word that people use to describe a very rare condition. So use this to your advantage. Ask that open-ended question. The next one, radiation. This is, does that pain move anywhere in your body? If you're having crushing pain in your chest, do you feel it anywhere else? Like I've been saying, oftentimes people who are having a heart attack will feel it radiate up into their left arm, their left shoulder, or their jaw. And so we want to know, does that pain move anywhere else in their body? That's another thing that can really help us determine what's going on, or at least help the hospital determine what's going on. S, we've got for severity. This is that standard doctor's office question where you're going to say, hey, on a scale of 1 to 10, 1 being no pain at all, and 10 being the worst pain you've ever felt in your life, please rate your pain that you're having. Right? This just gives us an idea of what that patient is going through. Everybody has a different pain tolerance. There isn't like a scale that we write down that like gets people pain medications versus what doesn't. It is all just about understanding this patient's limit of pain. I'll let you know if somebody says, if I say rate it on 1 to 10 and they go 11, I put down a 10 because they do not understand scales. They do not understand directions. All right. They can't be 11. It has to be 10. That is the most. It's a personal thing. All right. People, like, you'll say on a scale of 1 to 10, 10 being you're on the ground, unable to speak, worst pain of your life, describe it. And someone with like foot pain goes 10. I go 7. Got it. Cool. And then after that, we've got time. When did this start happening? How long has it been happening for? It's a little bit different than onset because we want to just ask the question of, has this happened before? How long have you been dealing with this issue if it's a reoccurring thing? So when I'm talking to somebody who has chest pain, right? I introduce myself, I get their name, their level of consciousness, their ABCs, and I'm going to say, hey, when did this start, right? How long ago did you start having chest pain? They say 10 minutes. I'm going to say, all right, is there anything that you can do that makes it feel better? They might say medication. And I say, what caused it? What started? What were you doing when it started? They say running around, right? Okay. Can you describe that pain for me? Oh, it feels really crushing and it radiates. great, you answered my next question. And then on a scale of 1 to 10, how bad is it? They say 8. I say, uh-oh, that's not very good. That sounds like it's very painful. How long has it been going on for? And they say, well, I had a heart attack 2 years ago. I get intermittent chest pain, but this feels a lot worse. And I say, let's go to the hospital, right? So we want to start putting these into our brain, because these are the questions we really need to start asking our patients, especially if we are trying to get down to what is going on. These are the questions the doctors are going to want to know. We can start getting a really good history of this patient and a really good idea of what's happening to them. So that's our next acronym, that OPQRST. And that wraps up something we call our primary assessment. What we want to know first is this patient sick or not sick? And we do that through our ABCs and their level of consciousness. After that, we're going to get some information about what in general is happening, why they called 911. And then after that is when we can start delving into some of their more specific complaints. Not everybody that we go to is going to be having a heart attack, right? It could be somebody fell off a playground and they broke their arm. And we show up and we clearly see that the only injury they have is a broken arm. We're still going to ask them and do all of our assessment and do that question. But once we've ruled out any other major emergencies, we can just focus in on that arm, do a specific assessment, start planning our splinting of it and our treatment of it, right? And so that's where we can actually take our time to delve in on the main issue. But we do need to go about it broad at first. We need to rule out anything that might kill our patient that we could be missing before we narrow in and we focus down on our secondary assessment. And this is only ever done after ABCs, right? If we show up and we see a broken arm, I'm not going to just go run and start treating that broken arm before I've checked to make sure my patient can breathe and can speak and has a pulse, right? So we only do those focused assessments after we've done our big assessment of, are they okay? Are they going to be okay in the next hour? We could also do things like listen to somebody's lungs or check their C-spine, that part of the neck, if we're worried about like neck pain, right? But we're still going to make sure that we check their airway, their breathing, and their circulation first. So here's just an idea of when you might conduct some of these assessments, right? So somebody who is complaining of like a medical issue, they're conscious, they're awake, they're alert, and they're complaining of something going on. We're going to want to get their OPQRST. We're going to want to get their vital signs, their medical history, and then do a physical assessment as appropriate. Someone's complaining about difficulty breathing, we'll do a physical assessment of their chest, make sure that we don't see anything weird, and we might listen to their lung sounds. If somebody is altered or unresponsive, they're unconscious and unable to tell us what's going on, that's when we're going to have to delve in and do some of these assessments, right? So level of consciousness, that's when we're going to do the, hey, are you okay? Maybe even providing a little bit of painful stimulus to see if that makes them respond. We're going to do a physical airway, breathing, and circulation check. We're going to open their airway, look inside. We're going to look at their chest, listen and feel for breathing, and also check that pulse. And we're also going to do a head-to-toe assessment. I'm going to palpate from that person from the tip of their head down to their toes and look at their body to make sure I don't see anything, right? Somebody found this guy unresponsive, had to open up his shirt to find this scar, right? If this shirt is all closed up, I might have missed the fact that he had a recent major cardiac surgery and could be having a cardiac problem. But if I do that palpation, I check his chest, I see that scar, I'm going to say, wow, let's put an EKG on this guy, or let's call some extra help because we need to get him going. I think he's having a cardiac issue, right? So it depends on our patient is what we're going to be able to do. Are they going to be able to walk us through? Are we going to use them as the history? Are they going to give us the answers to our questions? Or are we going to have to find them ourselves? And then anytime we have a patient that we're transporting up to the hospital, it's not enough just to assess them once. We're going to want to reassess them every so often, depending on how sick they are. If somebody is really sick, we're going to want to reassess them every 5 minutes or so. Whereas if they're not sick, we can wait every maybe 15. So Kiara, great question. It's not within your scope to like listen for specific sounds. Like we're not going to be taking our stethoscope and listening for wheezing or anything like that. But I am going to we're going to have stethoscopes to play with, and I'm going to show you those spots, and I'm going to teach you how to listen for like presence and quality of air going in and out of lungs, essentially. VEFR doesn't have, and even EMT, the basic level, doesn't have the ability to like diagnose lung sounds, but we will be practicing with those and just learning how to take them. So the reason we assess or reassess patients, right, is to see if what we're doing is working and to see if they're getting any worse or any better. We can also just detect changes. If somebody's first complaint was they're having chest pain and it was a 10 out of 10, and now we've started transporting them, they've maybe like a paramedic is giving them some medications and they say, you know what, I'm feeling a lot better. That's great. That just tells us what we're doing is working. Versus if somebody started off with chest pain at a 5 out of 10 and now they're at a 10 out of 10 as we're transporting them, we're going to say, oh boy, it's getting worse. So we need to be checking our patient constantly. We need to make sure that we're doing the right thing. And then, of course, documentation needs to happen. After any time that we engage with a patient, that we talk to a patient, anytime that the ambulance or really anyone goes out the door in the events of emergency, we need to document it. It is just the nature of the world that we live in that we need to have this type of report that we went out, that we did something, so that nothing can be misconstrued. Documentation is a vital, vital part of being an EMT, right? We deal with life-threatening situations for patients. Some of the things that we do are hoping to stop somebody from dying, and we just need to document everything to protect ourselves and to protect our patient. It's really very beneficial for doctors at a hospital to have a new patient come in, somebody who's visiting from out of state, and they just type their name into their medical record software, and it comes up with everything that they've ever been to the hospital for, including any report that somebody on an ambulance wrote and submitted for them. Especially in the state of Vermont, ambulance medical reports become a part of that patient's like permanent medical history. So the things that you write if you end up transporting someone to the hospital will be in their medical chart forever, essentially. You know, at the scope of the VEFR, you are likely not going to be the ones who are in charge of writing a full patient care report. It's more likely going to be like the crew chief on your call, but it is really important that because you might be working in a first responder situation, that you understand how to do this, because you might need to be the one documenting about medical care provided to a patient. The other thing that makes this important is if there is any situation, any call that we go to that ends up with the patient going to court, you might be subpoenaed. That's one of the things, is that if we write a documentation, if we responded to a call for somebody who was involved in a crime or something like that, they might subpoena you to come in and speak at that person's trial about what happened during the event of your medical emergency. And it can take years for the court process to work. So if you didn't do a good job on documenting this call 2 years ago, and then you get the call saying that you need to go to court, and you show up and you don't remember, and you look at your form and you just did a crap job documenting, you're going to be looking like an idiot, and it could lead to legal ramifications for whoever that was. So it is very, very important that we document thoroughly. Really, if you don't write it down, it didn't happen, right? Mandated how? Kiara. It is mandated that we document after every single call. Yes, it is not legal for us not to document a call that we went on. If we don't do it, that's a big, big no-no. Every department has somebody whose job it is like going through all runs, all calls that have been submitted, and verifying that they're correct. Yes. A subpoena means you are legally required to show up under fear of law. It's not the fact that you're in trouble, right? If being subpoenaed means that, hey, any other day, if a cop comes up to me and says, hey, what happened on that call? I am legally required to say, you know I can't answer that. Where do you want to go, right? I'm not allowed to give any sort of patient information, and we're going to talk about that in a little bit. So the reason we get subpoenaed is so that we can essentially break HIPAA. We have a law that requires us not to talk about patient information, even to law enforcement. So the reason we do that is just to so that the legal system can understand what happened on the call without us breaking any laws. So as getting subpoenaed means that I'm coming into a court and I can talk about that call to people who weren't there for the reasoning of just better information, right? So yes, if you get subpoenaed, you need to go because you were the medical provider there. So it depends. Kiara, that's a good question. I was saying that as a VEFR, unless you are the only medical provider there, you're not going to be the one who is in charge of documenting the call or writing the patient care report. That is going to be the highest level of medical provider there, or the crew chief, right? So if you and I were on a call together, I would be the one documenting because I'm an advanced EMT, I'm the crew chief. So I would be the one doing that. I would write you as a crew member, but you're not the one signing off on it. So there's always somebody signing off on it, but if you are the one who's writing that report, you were the main level of care provider there, it's just you, right? You need to sign off on it, so you need to make sure you're doing a good job. That's one of those things. So how we do that is we use this acronym. It's called CHART. Essentially, it is just a way to write and memorize or write down what happened on the call. So CHART is I'm not going to have you focus on this because as a VEFR, you're not going to be the one actually submitting patient care reports, but it is beneficial for you to know how to do it. So this is chief complaint. What did the patient complain about? Why did you get called? So chest pain. H is history. So that's where you write a paragraph about what the patient said was going on. It's subjective. You write down what the patient told you. And then assessment, A, is you write down what you found in your assessment, the objective findings. R is response to treatment. So what did I do? And how did they respond to it? Did they get better? Did they get worse? And then T is transport. How did you get them to the hospital? What did you bring with them? Did you bring any of their own belongings? Where did you bring them in the hospital? So another reason why we're not spending a lot of time on this is every service does it differently. Every service has different preferred ways for their members to document. So this is just the standard way that we teach. But once you start working for a service or you become affiliated, they are going to walk you through how they want you to document calls that you go on. And they're only going to let you start doing that once they have verified that you know how to do it. But if I taught you exactly how to do it my way, you're going to go to different services and they're going to want to change it all around. So give you the idea of why it's important, the basic acronym, and then let your services dictate how you document. Good questions. Remember, if you didn't write it down, it didn't happen. And that is not to say that if you did something wrong, don't write it down, because they will still be able to figure it out. All right, that is patient assessment. Those are the basics for it. Now we're going to get into some of that altered mental status talk. So the first thing I wanted to do is I want to play a little game. I'm going to show you two pictures. It's one of those find the difference, right? Some of them are going to be a little bit different. So I'm going to show you the two pictures, and I want you to see if you can see the differences, all right? I promise it's not a jump scare. See any differences? All right, what about now? Yeah, I'd say you could see some differences. You laugh, but let's watch this video. And there it goes. All right. Now there's a couple different reasons why I show you this video. From our angle here, we have no idea what's going on. Because it's an ambulance, I'm assuming that this guy is not doing well. He was considered to be altered, right? Out of his normal mind, which is why he obviously doesn't want to go, but these EMTs are making him. Now, what could also be happening is that this guy stated from the beginning, I don't want to go to the hospital, but these guys were making him. How do we know? That's by going to class, right? Talking about legality and consent. So we do have to worry about this. There are 3 types of consent that we're going to have to get or understand before we can start transporting patient, right? It's not okay to just show up and start treating somebody without their consent. So the first thing is expressed consent. This is somebody who is an adult, somebody who's over 18 or a legally emancipated minor who is able to prove with documentation that they have on their person right then and there that they are of sound mind. So if they answer those questions I told you earlier, they know their name, they know where they are, they know what they're doing, and they know what time of day it is. That makes them what we call conscious, alert, and oriented times 3, or CAO times 3. Basically, it means they are able to make their own decisions, right? They are their own mommy. This also affects minors. If there is a child who is sick or injured, we need to get consent from their parent or their guardian before we can transport them. Now, in EMS, there are situations where somebody is going to be unable to speak to us or unable to give consent verbally. No, both parents do not need to give consent. It needs to be one of them, essentially the one who is with them. This, you're starting to get into the area where it gets a little bit complicated, but essentially if somebody is somebody's legal guardian, they give me permission, I'm going to transport them, especially if they need it. Now, in those situations where somebody's not able to speak to us or give us their consent verbally, but due to the circumstances, I'm able to say that this person would likely give me permission to treat them or their child if they were responsive. Essentially, this is me saying any normal human being would want me to help them in this situation. Because they're unable to tell me that, I'm going to assume that they want me to help them. So this is people who are unconscious due to drugs and alcohol. This is people who are in cardiac arrest. This is people who are just like a little bit altered, confused, having strokes. People who need to go to the hospital but are not able to make the decision themselves, or who aren't able to tell me to treat them. So essentially, we become their mom, right? We show up, they're not able to respond to us. We know they're sick. We say, I'm bringing you to the hospital. Suck it up. And we're going to be protected, right? This isn't something that we're going to abuse either. This isn't us saying, oh, they were intoxicated, so we brought them to the hospital with implied consent against their will. We're using this for people who need it, right? We are going to treat them because they're going to die if we don't. And if they don't give us permission, we're just going to be standing there going, okay, well, maybe they'll wake up. No, we're going to help them. This is also the case for when there is an injured child and we are not able to get in contact with their parents. Let's say there's a kid who just started learning how to bike, right? And their parents said, stay within the neighborhood, right? You don't have a cell phone yet. Kid goes out of the neighborhood, decides to go bombing down the big hill down the road, crashes out at the bottom. We don't have a cell phone. We don't have their parents' cell phone number. They don't have a cell phone. We can't get in contact with their parents from where we are. We try our best, but that kid's hurt. I'm going to transport them to the hospital, and I'm going to do my best amount of work to try to get that parent's phone number, but I'm going to focus on treating that kid. They will figure it out. They will be called by the hospital. That is covered under implied consent too, as long as we have tried to get in contact with the guardians. Now, the last one we're going to talk about here is called protective custody. This is a very specific situation, and we are not placing somebody in protective custody. We are going to be working with law enforcement in this situation, a police officer, and we are going to request that the officer put this person in protective custody. This only will happen when we believe somebody to be a danger to themselves or others, what we would call incapacitated. So, if somebody has stated that I want to hurt myself, I have suicidal ideations, or I want to hurt other people. Or somebody is so drunk that they want to get in a car and drive, and they're refusing to stop that idea, or they just want to go. Right? This is those times where we're going to say you're a danger to other people. Even if you can tell me your name, your date of birth, what's going on, you want to hurt yourself, you want to hurt other people, I'm not legally allowed to leave you. I'm going to have law enforcement, I'm going to request them, put you in protective custody so I can bring you to the hospital. So essentially, police become their mom, you become a babysitter. The police put them into protective custody. The police say, I want this person to be treated at the hospital. I'm going to give him to you. All right? These are very important. If we take somebody to the hospital against their will, you are kidnapping them. All right? Yeah, Kiara, what's your question? Oh, it's in the chat. Is it the same one? No. Tattoos are not legally binding. If somebody has a DNR tattoo, I'm going to have a small chuckle, and then I'm going to continue doing CPR on them unless I am given the appropriate paperwork signed by them and a doctor. That's a good question, though. When we talk about cardiac arrest, we will be talking about DNRs. I'm sorry, Kira, that was pretty broken up. I couldn't hear you. Your microphone sounds like you're underwater. I'm sorry. Type it in the chat. I'll continue, and then I will read it once I see it. So, we need to take very, very good care of this, because like I just said, we can get in trouble. If we transport somebody against their will, who doesn't need it, who has said no, we have kidnapped them. All right? These 3 quick questions help us determine whether or not they can give expressed consent. What's your name? Where are you right now? And what time of day is it? We need to ask every single patient these questions, if possible. If they answer all 3 of them correctly or reasonably, we consider them to be conscious, alert, and oriented. Effectively, they can make their own decisions, even if we don't like those decisions. But if they only get 2 of them right, if they don't know what time of day it is, they say, yeah, my name's Kevin, I'm in my house, and it's midnight. Sorry, not of sound mind. They don't know their name. That's pretty bad, right? If they don't know where they are right now, that's very bad. So they have to get at least 3 of these questions right to be considered of sound mind. If they are not, we are not legally allowed to leave them because they're altered and they need transport. But what that also means is that they, even if they're sick, could say, no, I don't want to go to the hospital. All right. It's time for our break. It is 6:34. I went 4 minutes over. Sorry about that. Let's come back at 6:50. I'll always give you 15 minutes, and we will finish off our presentation then. So I'll see you in 15. Have a good break. Welcome back from break. Get some water if you haven't already. Hydrated, hydrate. I refilled my seltzer, so we're all good. Anyone have any questions for break? Coolio. What flavor? Great question. That's what I'm always asked. It is a watermelon strawberry like spray that I put into my soda stream. I like it a lot. I'll drink like 4 of these a day. It's good and bad, you know. Water, whatever's in that spray. All right, but here we go. So we just talked about what questions we need to ask in order to make sure that somebody is of sound mind, that they're able to give their own consent. Those are those questions. What their name is, where they are, and what time of day it is. Now, again, we need to do this because we need to be able to responsibly transport somebody. Now, the other thing I wanted to talk about when it comes to legality is that idea of the Good Samaritan law. Currently, as of now, you guys are lay people. That means you have no medical certification. You are currently in a training to get one, but you're not legally a VEFR yet. So that means if you witness an emergency and you go to help and something that you do isn't correct, you are going to be protected under something called the Good Samaritan law. Because you are genuinely trying to help, even if you didn't do those things correctly, the law protects you. However, when you become legally a VEFR, that means if you're on duty, if you are acting as a VEFR for a department and you respond to a call, you have a legal obligation to help whoever called for whatever reason. Failure to do this can mean that we get in trouble, essentially. So that means, right, maybe we show up. We're on first response duty. We get a call before work or before school, right? And it's the house next door. Somebody's having chest pain. So we grab our stuff. We run next door. We start administering care. We do our assessment. And we start helping them out, right? And we look at our watch and we say, oh boy, the ambulance is 20 minutes away. My teacher said that if I'm late for class again, I'm going to fail. And if I fail, I can't graduate. So you're good for the next 20 minutes, right? I took some vitals. Like I'm going to write it on a piece of paper. I'm going to hand it to you. And then I'm going to run to school. Ambulance is going to be here in 20 minutes. You got this, right? And then you leave. That is called abandonment, right? You've responded. You have to help that person. Another example. Someone calls 911. You show up first and you realize it's your ex who broke your heart and you hate them, right? Not over it. And they need medical help. And you say, no way in hell, right? And you walk away. Guess what? Abandonment. You're going to court. We have a duty to act as a medically certified person, right? So if we're on duty and we get called, we need to help, no matter what the situation is. If we're off duty, we're only going to be legally required to help if it's safe to do so and within our ability. But we're not legally required to help. The minimum that we need to do is call 911, all right? But once you are certified, you can only act within your scope of practice. So that means if you show up and you pull a Sandra Bullock in heat and you try to do a surgical crike with a steak knife and a straw, guess what? You're losing your license, probably going to jail. But if you show up and you act within your scope of practice as a VEFR, then you're going to be fine, all right? So this only covers a lay person. Once you become VEFR certified, you're no longer a lay person. Ellie, I'm going to check in about that about woofers, because from what I know, like a woofer certification, like a wilderness first aid, it's not a license. You're not getting certified through a state. It's more of a class certification. I'll look into that, but I don't think you have a legal responsibility to help out in emergencies. It's just if you help out and then you do something that you're not trained to do, that would be a bit of an issue. Great question. All of this to say, as a medical first responder, you are not law enforcement. Your job is not to get somebody in trouble for why they are sick or injured. If somebody is too drunk or high on drugs that are not legal, it is not our job to report them to the police. Our job is to transport them to the hospital. All right? Even then, we cannot just act outside of the law because of what we do. If we act in certain ways, we can be in trouble. Right? Here are all the felonies, not all, but a lot of the felonies medical providers can accumulate. Negligence. That is if a patient sustains harm directly due to our incorrect actions. If we drop somebody, if we don't care about them, we don't give them a medication that they need, if we treat them so poorly that they end up getting hurt, right? That's negligence. This happens. Recently, in the past couple years, there was a pair of paramedics, forget what state it was in, it was like Indiana or something like that, where they transported a patient who was having alcohol withdrawals, prone, face down on a soft stretcher with a pillow, and they strapped him down really, really tightly so he wouldn't move, and he suffocated and he died. All right, so it can happen. We need to be constantly aware of this. Abandonment was what I was talking about earlier. If we begin treating a person, we must stay with that person until a person of the same level or higher comes over to take care of us. So as a VEFR, if you're treating somebody, you can only hand that patient off to somebody who is a VEFR or higher. So if an EMT comes, you can, and you needed to go to school, you can say, hey, I'm going to give you a report. I got to skedaddle. You're an EMT. You're in charge now. But you can't do it if a CPR certified person comes up. Battery. This is if you touch a person of sound mind against their will. So if somebody says, I'm conscious alert oriented ×3 and you are not allowed to take a blood pressure on me, if you move and start taking a blood pressure anyway, you have touched that person against their will. They have a sound legal case against you for battery. Assault is if you threaten to harm somebody. So if you're like, listen, you need care, get in the ambulance right now, or I'm gonna slap you one, right? That's assault. If you threaten somebody with harm, that's assault. And then false imprisonment or kidnapping, this is if you transport or restrain somebody of sound mind against their will. All right, so you need to gather that conscious alert oriented ×3 questions before you can do anything. One of the more challenging situations that this comes up in is somebody who knows that they are sick, somebody with a long-term chronic condition or a condition that puts them on like hospice or something. We have, and I have definitely showed up to these situations where there is the family of somebody who is terminally ill at home, and the family is requesting that you transport them to the hospital. But the patient, even though they have terminal cancer and they know that they're sick and probably going to die, is conscious, alert, and oriented ×3. And if I transported that person against their will, I would be kidnapping them, even if the family members want me to bring them. So that's what we have to keep in mind. We cannot force somebody, even if they're going to die, even if they're sick, to the hospital if they're conscious, alert, and oriented ×3. And that's challenging, all right? So let's talk about a case. Here's a situation. We're called to a house for the report of a person who is not acting right. When we show up, we find an 88-year-old female sitting in her chair. She's looking confused, but she looks happy. She's smiling. Her caretaker immediately says, I'm an LNA. I came to check on her. I've never met her before, but she's altered. She's way off of her baseline, and I think she needs to be transported right now. I think she's having a stroke. Her vital signs are pulse of 62, respirate of 12, blood pressure of 90/64. She's on home oxygen. I made sure she took her meds, which is lisinopril, gabapentin, dilaudid, Coumadin, and insulin. She has a history of coronary artery disease, diabetes, cardiovascular attack, and AFib. The patient tries to speak. The patient says, I don't really, and the LNA says, shh, sweetie, it's okay. Don't be scared. You're having a stroke. They'll take good care of you. Yeah, so LNA is a licensed nursing assistant. What do you think? What do we do? Exactly. Sure. We have another person here who's medically oriented. But we haven't done our assessment. I'm going to take everything that this LNA says, I'm going to document it, and I'm going to continue my assessment, and I'm going to make sure that I'm not kidnapping this lady. I'm going to listen to what this woman says, or this LNA says, and I'm going to do my own assessment. But I'm not going to transport this woman just because of what this person says. I'm going to do my own assessment first. All right? Just for your information, these vital signs are not too far out of the realm of normal for an 88-year-old female. She is on a lot of medications that could make her altered. She has diabetes. She has a history of strokes. She has a history of heart attacks. There's a lot of things that could be going on. It's not just enough to say, yes, she's having a stroke. We need to do an assessment. All right? That's because altered mental status, or AMS, is a change in somebody's mentation, their baseline ability to think and comprehend. It is always a serious problem, and it's either due to like a physical issue or a metabolic problem, so something going on within our body. Our brain is really, really important to our ability to function. And if somebody is altered, if somebody is not able to process correctly, something is significantly wrong. This can range and be due to a bunch of different reasons. It could be due to the development of a brain tumor. It could be due to lack of blood, or it could be bleeding inside the brain. Somebody could have a really bad head injury, a concussion, maybe even worse. There could be a degenerative disease of the brain, like a Huntington's disease or ALS. They could be having a stroke. They could just be having not enough oxygen, hypoxia. Their blood sugar could be low. They could be having organ failure. They could be having seizures or drugs or alcohol, right? There are just so many different reasons why somebody could be altered, but it's always very severe. It's always, not to say that like they're going to die because they're altered, but it's a major sign that something is wrong. If their brain has been affected, if the brain is altered, they're not getting what they need. So when we do assessments of somebody who's altered, we really want to take a look at the scene. What is around them? What is around us? Why might that be important for altered mental status? Sure, yeah, sharp objects. Whether it be something that hurt them, that might hurt us, or if somebody's altered, they can be unpredictable. And if they're angry, if they're agitated, we just don't want them around any weapons that could hurt us. Yeah, leaking chemicals too, right? If somebody is in a closed room and there's a gas leak, they might become altered. And if we're not aware, if we walk into a room where there's a gas leak happening, we could also become altered. And then absolutely, if you walk into a scene and you're wading through alcohol bottles, like empty alcohol bottles, and somebody's drunk, it's definitely safe to assume, hey, maybe they've had some alcohol. Let's do an assessment for that. The presence of drugs and alcohol on a scene does not automatically mean it's a drug or alcohol related call, but it's definitely something that we can add to our list of assessments. Good job. So then, especially with altered mental status, this initial assessment is key, the orientation and their level of consciousness. If they're altered, if they're unresponsive, that means they're altered. That means something bad is happening. But if they're conscious, but they're confused, that's something else to keep in mind too. Are they able to make their own decisions, or do we have to transport them using implied consent? I put this little picture up right here because this is one of the things we want to check somebody's blood sugar as quickly as we can. It's not within your scope of practice, but it is within an EMT scope. And this can really help us determine what's going on. If somebody's altered, one of the first things we do is check a finger stick. All right? So now, I want to do something real quick. Just going to switch it up a little bit. What I'd like us to do is I'm going to read you a little bit of a story. And I want you to close your eyes. I want you to take some deep breaths. And I want you to picture yourself in this situation as much as you can. All right? I'll do it with you. So imagine, if you will, that you are sick with a terrible flu. Your entire body aches, you're shivering, but you're sweltering, you're starving, but any food you eat or water you drink makes you feel nauseous and want to vomit. You endure days upon days of this, and you become more and more exhausted, You see doctor after doctor, and none of them can tell you what's happening, but you begin to wonder if they don't know or if they just won't help. Finally, the day comes when a doctor tells you, we figured it out. Unfortunately, they say, it seems that this is a serious disease. Due to the nature of how it works, you're never going to feel any better, you're in no danger of death, yet you're going to feel this sick forever. The doctor continues, however, there is good news. There is a new medication that has been painstakingly developed, tested, and approved for use by the most esteemed researchers in the whole world, and it's been shown to eliminate all of the symptoms you're experiencing. It's relatively cheap, while it's covered by your insurance, and the first dose is free. You don't hesitate, you take that medication, and instantly you feel better. You are hit with a wash of euphoria, and you realize that all of your ailments have been cured. You feel better than you ever have in your entire life, and you realize you never want to feel that sick again. You thank the doctor, and you go about your life as usual. Now, a few weeks later, you begin to feel sick again. At first, you're confused. Sure enough, you took your medications this morning. You felt great this morning. Why is it coming back? You're immediately worried, so you call your doctor. And they say, oh, that's totally normal. My bad. One thing I forgot to tell you about the medication is that it's tolerance producing. You're going to need to take 2 pills every day now in order to get the same amount of effect as one. One in the morning, one in the afternoon. And you're going to need to up that dose higher and higher every week unless you want your symptoms to come back. Oh, and make sure to just take enough to keep your symptoms down, but don't take too many in one day or it could be dangerous. You could die. Oh, and your insurance only covers up to 2 pills a day. So in a few weeks when you're doing more than that, you're going to need to pay out of pocket to keep your dosage the same. Oh, it's $600 a pill? You can't afford that? Oh, well, the other option is to buy the medication somewhere else, but that's dangerous. Because if you're caught with that medication somewhere else, you're going to be tried, jailed for possession. You can open your eyes. We're going to talk about opiates, narcotic medications. For those of you who don't know, opiates are just a really effective form of pain control. Right? We're going to be talking a lot about what we call the opiate epidemic in the next 45 minutes or so. But really, what these medications were intended to do is what they do. They are intended to reduce pain, and they have been around for a long time. Opium is a naturally occurring flower, or it's a naturally occurring substance within the milk of something called the poppy flower. If you're from Vermont, you know what milkweed looks like. It's essentially the same thing. A flower excretes milk. From that milk, people would rub it on wounds, they would ingest it, and they realized that it helped with pain a lot. From there, they extracted opium. And even hundreds, maybe even 1,000 years ago, people were abusing this substance. But they were also using it for medical reasons. And once we started developing more and more through science, we were able to extract the molecule from that opium, and morphine was made. Morphine, which is still used today in medical situations, became one of the first medical, really effective pain control medications. Saw lots of use and development in battlefields like World War I, World War II. Medics were carrying it, started going out to hospitals, and it was stronger, had a more potent effect than opium. Now, as we keep doing, we create stronger and stronger medications as we learn. From morphine, something called heroin was created. Heroin, yes, it too was intended to be a medicine. Bayer, the company that manufactures aspirin and a whole bunch of other medications, Bayer, in the early 1900s, had a children's cough syrup that included heroin, ether, and cannabis, marijuana. They realized that, hey, maybe the kids are sleeping a little bit too deeply. Sure, it's stopping them from coughing, but it's a bit strong, and they also realized it's very addictive. Still didn't stop its medical efficiency, though. So, Heroin is no longer used as a opiate for medications, but we did create something stronger called fentanyl that we do use. It is approximately 10 times more potent than morphine. It's very strong stuff. That being said, right, we dose morphine. If we're going to give it to a patient, we dose it in milligrams. If we're going to give fentanyl to a patient, we dose it in micrograms. It's that much stronger. Now, it is very effective in medical situations, but it is also an opiate, so it's very addicting. And then, hey, you know, humans being humans, we just want to see how far we can go. Somebody created carfentanil, which is an elephant opiate, meant to tranquilize elephants. It is approximately 100 times more potent than fentanyl. Yeah. Right? These things are very strong. The carfentanil was never meant for human consumption, but guess what? Humans take it. Right? So, opiates. These are very effective drugs at quelling pain, at reducing pain. Here's that poppy flower. Then we morphed to morphine. Morphed into heroin, which there are different types of. To fentanyl, and then carfentanil. Now, here's a picture of a lethal dose of pure heroin. If someone was to inject that, they would probably die, most likely. Here is a lethal dose of fentanyl. And here is a lethal dose of carfentanil. So right away, we can kind of tell what some of our concern is one, it's almost impossible to tell which drug is which. If I emptied these two bottles into the heroin one, shook it all around, and then dumped it out onto the table and told you, separate the fentanyl and the carfentanil from the heroin, it would be impossible. And this right here is one of the first reasons we see overdoses. Now, we're going to talk about why people are addicted or why there's an opiate epidemic in general. But one of the things I always hear is like, oh, people want to, like, they wanted to overdose. They wanted fentanyl, right? But here's the deal. Dealers, people who sell heroin and opiates, they have a business to run. They don't want their people to die. Right? They want somebody to buy drugs. However, they want to make money and they want to make a name for themselves. So, a dealer has a big batch of heroin and a small batch of fentanyl. They will take that heroin, they'll cut it in half. They will then cut their fentanyl in half. They will take those two and they'll mash them together, essentially mixing heroin and fentanyl, where we can't tell which is which. They then sell that. And some people will get a really potent heroin that they don't overdose on because there's less fentanyl in it, because when you mix red and blue sand together, you're never going to get a perfect distribution. And then there are going to be some people who have mostly fentanyl in what they're expecting to be heroin. And those people overdose. Now, the dealer has sold that fentanyl-rich heroin for $10 a bag, and other addicts have heard that people have been overdosing on their batch, and they say, wow, that guy must have really strong stuff. I want to buy from them. They will then take that other batch of heroin without fentanyl in it. They'll mix it with other things, like drugs like xylazine, which we'll talk about, or random things like baby laxatives and vitamin D powder, and then they will then sell that for the same price as the other. It's messed up. People are overdosing, but I can guarantee you that no one woke up and said, I want to overdose on fentanyl or heroin today. Right? Here's the other question I have for you, because I've heard a lot of things about this. I want to know what you think. Is it safe for us, or is it dangerous for first responders to treat somebody who is overdosing? Is there a risk that we are going to overdose ourselves? I see some yeses. I see a no. little bit of explaining. No risk, no yes, yes. Okay, so maybe we're not going to be in danger of overdosing, but the patient could harm us. Then you say with the proper preparation, no danger. Yeah, that's what I would say too. With appropriate PPE, personal protective equipment, gloves, masks, eye protection, there is little to no risk of us overdosing. Even so, some of the things that have been said about fentanyl, heroin, and carfentanil is that it can be absorbed through skin or it can be inhaled and be overdosed on. That's not true. It will not absorb through skin with the potency needed to overdose, and the room would need to be something over like 75 to 80% full of like airborne fentanyl for someone to breathe it in. Almost impossible. All right. Some of the big videos that I have seen about this have been broadcast pretty far and wide on media outlets. And it has always been videos of law enforcement officers coming in contact with an unknown substance and then reporting that they are overdosing on scene. I was taught as an EMT that fentanyl would go through our skin. In carfentanil, if we were in the same room as it, there's a chance we could overdose. We started stocking extra Narcan on ambulances for ourselves, not for patients, just in case. And we have learned that it doesn't happen that way. It is impossible to overdose unless outside forces are at work. Here is a paper that said the law enforcement officers who came to this hospital or came to hospitals who reported that they were overdosing on opiates on scene either adamantly refused to be tested for opiates or were found to have none in their blood. If you watch the videos of officers handling these drugs in situations like the one I'm thinking of, a woman was in a vehicle, she pulled up a baggie and dropped a little bit of it and then immediately started hyperventilating, breathing really, really fast. And other officers gave her Narcan, and they claimed that they saved their life. What you're going to learn in a few minutes is that the main danger of an opiate overdose is a slowing of the breathing. People stop breathing. It doesn't increase. The science and the medical observations shows us that people in these situations were experiencing what looked to be panic attacks. You are only going to overdose on scene if you inject yourself or get injected with a large dose of an opiate directly into your veins. If you rub handfuls of pure heroin into your eyes, or if you snort a line of fentanyl off of your patient. Any other thing, being on scene, helping somebody who's overdosing, you are not going to overdose. Wear your gloves, dispose of sharps and needles and drugs safely, do not touch them unnecessarily, and you will be all right. Now, assessing for opiate overdoses. These are what we call track marks. Okay, these are the evidence of somebody using IV drugs. It doesn't necessarily mean heroin. Heroin is obviously the most common, but anybody who is injecting themselves at home with drugs will likely have some of these. This is just essentially damage done to the spots that they need to use to inject. The next video I'm going to show you, this is from a place called Kensington, Pennsylvania. Essentially what this guy does is he just takes a camera, puts it in the back of his car, and he drives down this avenue. And just wanted to show you some of the effects that you can notice on somebody who is intoxicated with opiates. So this woman, she is definitely on opiates. This is a pretty telltale lean where somebody is essentially passing out. They're feeling the effects of the drug, but they're still conscious. So this woman is not overdosing. I just want to make that clear. She is high. She is high on opiates. but she can stay up leaning over for quite a long time. These two are mixing a dose on the corner of the road. Now, I grew up in South Burlington, right down on Dorset Street, kind of by Shelburne. And I went to South Burlington High School. I went through school all the way through here. I went to St. Michael's College. I am a Vermont boy, all right? The first time I saw something like this in South Burlington was last year. It was 7 o'clock in the morning. I was driving to Hannaford's by the Target. San Remo Drive, I saw a group of 3 people right on the side of Dorset Street shooting up for each other. When I got to Hannaford's, I witnessed a guy standing at the bus stop doing that same lean that woman was. I worked on an ambulance for quite a long time. I went on lots and lots of overdoses. I had never seen it so blatant in my hometown.
The addicts cook the powder. Syringes are filled, preparing a drug that's now the same price as a 6-pack of beer and cheaper than cigarettes. Chasing a high that's ever harder to reach. Greg and Stacy live rough here. Lower Wacker Drive.
Just some things to point out. I missed it. Hold on. The reason I showed you the different pictures of heroin when I was going over what opiates are is not so you can, like, know. And so that you can show up and be like, wow, police officer, look at that black tar heroin. That's because I wanted to point something out about this video and about what our duties are as medical first responders. If somebody doesn't die from an overdose, they are going to die from other illnesses that have come from the habit of doing this. Black or white powdered heroin and like the yellow heroin, it needs to be broken down in sterile or like distilled water. It needs purified water. This guy is breaking it down in what I assume is dirty water in an old liquor bottle cap. He's then going to take that used needle that his friend probably had in his mouth, just like he did, with a used needle, and inject himself with this. If he doesn't get an infection, he's going to get a condition like HIV or hepatitis C, and it's going to lead to a whole bunch of other things too. When we do IVs, or anything that like punctures the skin, we make sure to clean the site in our hands so that they don't get infected. This guy's doing this multiple times a day with hands that dirty, right? That is not healthy. That's not safe. Now, this next video is a little bit longer. I do want us to watch the entire thing. It is kind of hard to watch. Just wanted to let you know. And the other thing about it is it's from a YouTube channel where a guy will go around in the same area from that first video, Kensington, and he interviews addicts, essentially, on the street. Now, I appreciate what he does. I really think that this video is impactful. I don't necessarily agree with the way he talks to some of these people. He's a little bit aggressive sometimes, so I just wanted to clarify. I don't all the time approve of how he speaks to this person, but I do think he really cares, and this is a very impactful video. So I'm going to step out. I'm just going to make myself disappear so I'm not ruining it with my weird facial expressions, but it's about 5 minutes, right?
Good evening, good evening. How you doing, sir?
I'm doing alright.
Can you speak up for me?
Yeah, I'm doing alright.
What's your name, bro?
Julian.
Julian?
Yeah, Julian.
Okay, good, good. How old are you, Julian?
19.
Wow. 19?
19 years old.
Where you from, Julian?
Upper Darby.
Upper Darby. That's a nice place, ain't it?
It's alright.
What brings you down here to Kensington today?
I've been out here for like 6 or 7 months now from doing drugs. And I'm doing drugs in general probably for at least like 3, 4, 5 years. I started off doing light drugs, smoking weed. And I started doing harder drugs and stuff.
You were introduced to drugs as a child? As a teenager?
Yeah, pretty much. Probably like 14, 15 years old. I'm trying to get things together, and but it's a little hard to right now because I'm on a certain drug that you need in order to like function, and if you don't have it, you go through withdrawals and like badly, and it's a little hard to get things together when I don't have it. So but I'm trying to get it so I can get my things together right now.
Now, Julian, what's your drug of choice?
I really don't like. I'm gonna just say dope. I don't really want to say the name of the dope,
He's talking about heroin.
but it is dope.
You said dope?
Yeah, dope. And that's the drug that's making me go through withdrawals, and which I need in order to function, in order to do things. Like if I don't have it, I can't. Like it's hard for me to like move around, walk. Like I go through anxiety. I can't think straight. Yeah. Like I can't eat, I can't sleep. Like it's really hard for me to do things if I don't have it in my system. But you was talking about my hands.
I was asking about them.
Yeah, these are abscesses from dope. You mind if I show you You mind if I show you a really bad one in my leg? It's a hole in my leg.
If you don't mind, I might be able to learn something from it.
All right. This is basically dead flesh. Like it starts to stink like dead flesh. Like every single time I'm around someone, they start to smell it. They don't.
Ooh, I don't know if I can get this close. Ooh, Julian, you're only 19, man. No, I'm good. Ooh,
Yeah.
Julie.
Yeah. It's bad.
You need to get to the hospital, man.
It's basically getting into my bones.
You need to go to the hospital. You need to go to the hospital.
It hurts when I touch it, so I try my best to cover it. And like I said, in the hospital, rehab, first I need to go through those things first. So like when I do get out, I have something ready.
You need help, man.
But yeah, I know.
So that was Julian. Julian is 19 years old. I don't know how old all of you are. There was a little bit of an age requirement, right? 16 or up. so some of you might be around his age. It's hard to watch, right? But the things that we glean from it, and what I was trying to talk to you about before, opiates are tolerance producing. So the reason people become addicted to them is because in order to get the same level of feeling they got the first time or what they needed for their dose, they're going to need to up that dose more and more, or else they suffer from withdrawals. Withdrawals that make you feel sick, like the worst flu you've ever had, where you can't eat, you can't sleep, you don't feel normal. Picture how you feel right now. Normal, right? Able to function. You're able to sit here and listen to me. You don't need something to be able to do that. People who are addicted do. And that's the issue. Now, our job as medical first responders is to figure out and assess to see when somebody is in danger of death or dying. We can actually pretty easily tell if somebody is overdosing on opiates. Now, that's an important word for me. Overdosing. So no, Zen, not all pain relief drugs do that. So Tylenol, it is like there is a level of tolerance for a lot of different drugs. Opiates are just really, really tolerance producing. To the point where if you were taking a Tylenol a day for ankle pain and you stopped after 2 weeks, you would feel like you wanted to die. You would feel so sick that you couldn't do anything but think about taking that Tylenol. And when you took that one pill, it wouldn't do enough. You would need to take 2. It's tough. But that's our job. Our job is figuring out when somebody is going to die or is at risk of dying from an opiate overdose. The opiates themselves, the drugs, they are not evil. When I was a kid and when I was first learning about overdoses, when I heard overdose, I pictured like the medication going into somebody's body and like being little evil, malevolent little like molecules, like stabbing somebody's brain and stuff. That's not how it works. When somebody overdoses on opiates, what we are seeing is the effect of the drug doing its job too well. It is a pain reliever. It is a pain suppressor. It stops very vital, or it slows very vital signals within our central nervous system. The things that controls our heart rate and our breathing. When somebody overdoses from opiates, they fall asleep and their diaphragm stops moving and they stop breathing. That is the main danger of an opiate overdose, is that they will stop breathing. So if we're looking at somebody and we're assessing them, if they're still breathing, even though we know that they have opiates, right? Doesn't necessarily mean we need to step in right away. So what we're going to look for is something called the opiate triad. Somebody who is overdosing will always have these 3 things. They will be altered. And if they are truly overdosing, they will be unconscious. They will not respond. They might be responsive to pain, but most of the time, guess what? They took a bunch of pain suppressing drugs. They're probably not going to feel the pain. Their pupils are going to be tiny. They're going to be pinpoint. Looks just like this. So you look at their eyes, you'll shine a little light in, you'll see very tiny pupil, indicates opiates. And then again, our main danger, the thing that we're really looking out for, is that decreased respirations. They might not be breathing, or they might be breathing like 6 times a minute, which is really, really slow, and that is what's going to kill them from opiate overdose. All right? Our job is not to give somebody who's high on opiates Narcan. We are going to be able to give Narcan, and we're going to talk about it in a sec. But we're not giving it just because we know or think somebody's on opiates. We're only going to give it if we think they're about to die from opiates. All right? And yes, Ellie, it's kind of like an opposite of cocaine or a stimulant or like a hallucinogen. In stimulants and hallucinogens, people's pupils go really, really big, whereas in opiates, they get really, really small. So this is what we're going to do. If we assess that they're not breathing enough, they have pinpoint pupils and they're altered, we're going to start by managing their airway. On Saturday, we're going to practice ventilating mannequins with pocket masks and BVMs, learning how to breathe for somebody who isn't breathing. We're going to start with that first. That might wake them up. We might not need to give them Narcan. We're going to do that for like a minute, and if they don't get any better, if we don't see any change, that's when we would start thinking about giving them that drug, naloxone. But the main danger of somebody overdosing is that their breathing stops. We have tools to breathe for them to try to wake them up first. They might just need a little bit of help waking up. But if they don't, that's when we give them medication. Okay. Hold on. That's my little medication baggie. Naloxone. Narcan. It's an incredible drug. Honestly. So cool. Not gonna lie. We'll talk about why in a sec, but first I want to get you all the information you need to have memorized for it. The only reason we're going to give somebody Narcan is if they are truly overdosing. If we see those signs of the opiate triad, specifically including that decreased respirations. Even if we see clear signs that they have taken opiates, they're unresponsive, they have pinpoint pupils, but if they're breathing okay, we do not need to give them Narcan. We need to constantly assess them to make sure they don't get worse. We should continue to help them, transport them to the hospital while they're unconscious, but they don't necessarily need Narcan. When it comes to the dose of Narcan, it's going to depend on what version of it you're giving. There are two different types that you see in these pictures. There's this one right here, or there's this one down there. And their doses are different. This one right here, this is 2 milligrams of Narcan. And we're going to give 1 milligram per nostril. It is an intranasal medication, so we spray it up somebody's nose using one of those. So we're going to give half of the dose in each nostril. Because it's a liquid and we're spraying it up there, we don't want to pump all 2 milligrams in one nostril. We want to spread it out. So we go back and forth between the 2 nostrils. A whole 2 milligrams. You have to give 2. However, if you're giving one of these, this is 4 milligrams of Narcan, and you're just going to give it up 1 nostril. The reason behind that is how they are set up. This one is all just self-contained. You just hit one button at the bottom, and it pumps it all out right here. No setup required. This was made for people who are not medically oriented, and then also first responders and police officers. Really quick, really easy. This one is 2 because it's made for medical providers, because an advanced EMT or up could give this through an IV if they wanted to. But you could also set this up to have one of those atomizers on the top to spray it in somebody's nose. All right, so that's the whole reason. If you're using one of these that you have to set up, 2 milligrams, 1 milligram per nostril. And if you're using one of these, 4 milligrams all up 1 nostril. All right? So the route, how it gets into somebody's body, is intranasally, in the nose. Now, the actions of Narcan, it's still getting its own name. I put an asterisk there because it can also be called something else. But essentially what that fancy term means is that it stops the opiate molecules in someone's brain from actually taking effect. It stops opiates from working. Really cool. Like a direct antidote to opiate overdoses. Now, it does have some side effects. But here's the thing that I like to tackle. In that previous question that I asked you, is there danger for first responders responding to opioid overdoses? One of you said, I think it was you, Ellie, maybe not an overdose, but the patient could potentially harm you. That is absolutely true. However, people often misattribute that to being a side effect of Narcan. I have heard medical providers say a side effect of Narcan is aggression. What a side effect means is that the drug has just essentially been tested, and the people who have tested it say there's a small enough chance that we think it's statistically okay to give this out, even though some people might experience this. So if it was true that Narcan had the side effect of aggression, I could take this Narcan right now, and there would be a chance that I would become aggressive and start hurting people. That is not the case. Narcan does not make people aggressive. What does is a sudden change in mental status. Right? Picture yourself. You just had like a really good day. You did whatever you like to do during the day. You hung out with your friends, you played disc golf, you had lunch, whatever it is. You get back home, you have your favorite meal. And then you have like a glass of wine if you're over the age of 21 and you feel super relaxed. You have like a nice hot bubble bath. And then you get into bed and you were like the most comfortable and relaxing you've ever been. And then you drift off to sleep. You're in an amazing sleep. And then boom, it's 3 a.m. You wake up half naked on the floor of your bathroom with police officers, EMTs standing around you, an IV in your arm. And you're like, what the heck is going on? And they're saying, what did you take? Right? You just went from being like super relaxed to super stressed out in a period of seconds. People tend to respond with aggression to that situation. So yes, people do have bad reactions to Narcan, but it's not because of Narcan itself. It's not a side effect. This will also play into what Narcan does. All right, I'm going to talk about that in a sec. One of the other side effects that you do see, though, however, is flash pulmonary edema. All right? So Narcan is very safe as long as it's administered in the correct time and in the correct dose, right? So you can only give up to 12 milligrams total, 5 minutes apart. I'm going to tell you a story. When these types of Narcan first came out, they were given to law enforcement and other first responders because of what I was telling you earlier, the scare of carfentanil overdose, like making providers overdose. So we started carrying these for ourselves. We got dispatched to an overdose in Colchester. So we respond. We get told on the radio that a police officer is there before us, and it's an overdose. He's going to give some Narcan. We show up maybe 2 minutes later, and I walk into the room. I see the patient still unconscious on the floor, and the officer comes up to me and he says, hey, I gave him some Narcan, but it didn't work. I gave him 5. And I take this from him and I say, sir, this is 4 milligrams. Are you sure you didn't mean to say 4? You gave him 4 milligrams? And the officer says, no, I gave him 5 of these. And I said, how long apart? And he said, oh, I gave 5 of them in about 30 seconds. And I said, why? And he said, that's what we were trained. We were told that these work instantaneously. So if you give it to somebody and they don't wake up, give them another one. So the officer found a guy overdosing, went 1, didn't work. 2, didn't work. 3, didn't work. 4, didn't work. 5, didn't work. I'm out of Narcan, call the EMTs. When really Narcan takes about 2 to 5 minutes to work. And in high enough doses can really hurt the patient. So that patient was sent right into withdrawals. He was throwing up the entire way, feeling like crap, and his lungs filled with fluid because of a side effect of taking too much Narcan at one time. He spent a week in the ICU, all right? One of these every 5 minutes while symptoms persist. Just 1 dose every 5 minutes, all right? Now, another reason why patients who are given Narcan might be assessed to be aggressive is because of how Narcan works. I told you that if somebody is addicted to opiates, they will not feel good, they will not feel normal unless they have a little bit of opiates in their body at all times. Narcan completely removes opiate effects from the body. It blocks the receptors in the brain, binds onto them, knocks opiates out, and will not let them bind. It essentially makes all opiates in someone's system null, meaning that if we give Narcan to an addict, we are putting them into severe withdrawals. So they wake up, sure, they're alive, they're not going to die, but they feel like absolute crap, and guess what? You made them feel that way. So we are in an opiate epidemic. We are transporting patients for opiate overdoses to the hospital daily. In Burlington, a couple months ago, there was a 48-hour period, 2 days, where there were about 190 EMS calls. To put that in perspective, my service that I ran on, we did about 300 calls a month. Burlington went on like 190 in 2 days, and 90 of those calls were opiate-related overdoses. 2 days. And oftentimes, it was the same people. Because guess what happens? If an addict overdoses, we give them Narcan. They are put into withdrawals. Their life is saved. They are able to refuse care. They go to the hospital. They check themselves out. And immediately, their first need is to redose themselves so they feel better. It is an endless cycle that is challenging for both of us. This is what I care about. This is what we care about. You are not directed to give somebody Narcan just because they're on opiates. If somebody admitted to you that they are an addict and they took heroin today, but their issue is a broken leg, and you give them Narcan, you are a bigot. You do not like addicts. You hate your patient. That is not what we do. All right? The only indication for Narcan is to save somebody's life due to decreased respirations. All right? I don't like to get like bossy and serious, but this is a huge topic for me. This is one I'm very passionate about. Here's some memes to break it up. I wanted to get this bumper sticker for my mom. She said no. And that makes sense to me. All right. I got one more story for you about opiates. So I was new at this time. I had like just become an EMT. This was 2015. And I wasn't like the crew chief on calls. I was still a helper, but it was my first kind of time as being like a certified medical provider. And I worked in Winooski for a long time, and we responded to a lot of overdoses, like multiple a week. So for this one, we got dispatched to an overdose. We arrived on scene. The crew chief gave Narcan. The person woke up, and then they refused transport to the hospital, as they're allowed to do. So the crew chief says, that's fine. He sends me out to the truck. I bring all the bags back. He's going to manage the paperwork, and then we're going to head back to the station. As I'm out front packing the truck, an officer rolls up in a cruiser. They had heard that there was going to be, or that there was an overdose, and they wanted to just come by and make sure we were safe. That's what I told him. That's what I'm legally allowed to say. I said, they overdosed. I didn't tell him a name or anything. I said, we gave Narcan, patients refusing transport. We're out of here. No big deal. Thanks for checking in. The officer said something along the lines of this. He said, oh, damn, you shouldn't have done that. We are at this house constantly for overdoses, drug deals, gun violence, domestic assault. Honestly, we're sick of coming here. It may have been better if you just let him die. And they drove away. So, here's my question for you. Who are drug addicts? Yeah. Exactly. They're people just like you and me. Nobody woke up. I can't say nobody. Majority of people woke up who are addicted today, and they did not think, hey, you know what sounds fun? Getting addicted to opiates today. Overdosing today. 70% of people who are addicted or who have tried heroin in the past 10 years started their addiction based off of a legally prescribed opiate medication. If you have been into the hospital system for any sort of surgery or physical injury within the past 10 years, you were most likely prescribed an opiate. I was. I did not get addicted, thank God, but I could have. The whole reason we have an opiate epidemic is exactly like I said so in the beginning. It was a medication that was painstakingly tested, developed, and funded by the most esteemed researchers in the entire world, and they pushed it on patients without fully educating people on tolerance-producing medications. Doctors were bribed by large pharmaceutical companies to prescribe more opiates than necessary. That is why we're here where we are, in an opiate epidemic. It's not because people woke up and said they wanted to be addicted. It's because they woke up and said, I need help, and a doctor prescribed them opiates. The other thing about treating opiate overdose patients is you're going to do it a lot. If you are in our state, you are going to see opiate overdoses if you work in a first response situation. Our job is not to cure these patients of their addiction. If you tell an addict to stop, they will not help. If you listened to what Julian said to the guy filming that video when he was crying and said, Julian, you need to go to the hospital, you need help, Julian looked at him and said, I know. If you get on the back of the ambulance or start showing up to overdoses and you think that berating somebody who just overdosed or somebody who uses opiates, telling them what they're doing is wrong or telling them that they're going to die because of it is helping, it's not. We are not going to be the ones who can fix them. What we can do is keep them alive for a day longer so they can make that decision themselves. It has to come from them. It can't come from us. But what we can do is we can try to keep them alive long enough to make that decision. We can educate them on safe use. We can talk to them about resources that are in our state. Like I was talking about earlier, and I showed you in that video, certain types of heroin need to be broken down in certain ways. If it's black tar heroin, they need citric acid, chemicals to break it down, but people use Sprite and oranges and limes and lemons to break down their heroin before they inject that into their veins. People lick their needles. People do all sorts of things. Share them, right? If we're with somebody in the back of the ambulance, we just gave them Narcan and we're transporting them to the hospital, or even if they're refusing to go with us, we can have a conversation with them as a human and ask them how they are using their drugs so that we can give them some pointers on how to stay alive longer. It's not our job to judge people. It is our job to ensure that they know when things are dangerous, and if we approach them with care and empathy and honesty, we actually have a chance of getting them better. The other thing I want to let you know is, it's really hard to do. This is a hard population of people to work with. I will be honest with you. One of the reasons why this is such a strong opinion and such a big, a passion for me to educate people on is because I did it so often. I was going on lots and lots of overdoses to the point where I was getting burnt out. I didn't want to help anymore because I was showing up, I was seeing the same things. I knew that when I gave them Narcan, they would just say, no, I don't want to go to the hospital, and I would probably find them overdosing later that day. They just started to get to me, right? But that's the job. We can't approach these people as less than people, because as soon as you start doing that, you don't get to call yourself a person anymore. As soon as you think you're better than somebody else just because of their situation, you're a bad provider. You're going to see people from all walks of life in this job, and if you judge them, you are worse than everybody. All right? It's hard to do. You need to stay constant on yourself to check your own biases. You need to take time when you need it. It's really hard to do, but you can do it, and you need it. These people need it. Now, some other resources we have is we have Narcan leave behind kits. Right? So essentially, if we show up and someone overdoses, we give them Narcan and they don't want to go to the hospital, we can leave a dose of Narcan behind. with a family member or friend and say, hey, if they go unresponsive again, they stop breathing, give them this, call us back right away. We can also do that safe use education I was talking about. And then we also have things like Howard Center resources where you can get Narcan for free. You can also exchange needles. You can get fresh equipment to use so you don't have to inject yourself with the same thing over and over again. There are withdrawal assistance programs, and the state is starting to pass legislature to start thinking about safe use spaces. That's one of the things, too, about this is people are like, there's too much lenience. We need to arrest every drug addict and send them to jail. And then the other side is like, there is too much aggression in jail. People just stay addicted to drugs. We need to have safe use spaces. Neither of them are working. If you look at the stats, nothing we're doing right now is working. What we are able to do is give people Narcan and then recommend them for treatment. What we need, we are still figuring it out. So right now, EMS, we are the people treating the addiction in America, and it's hard, right? Now, if you want to watch some more on this, I highly recommend a documentary on Netflix. It's called Heroin. It's a couple of years old now, probably like 2015. But it follows 3 women in West Virginia, where one of the big hubs of opioid overdose in our country, essentially. And it follows a deputy fire chief who is educating providers on Narcan. It was when Narcan was first coming out. It follows a gospel worker who works with people who are homeless and living on the streets. And it also follows a drug court judge who helps people get clean. There's a lot of really good videos of actual overdoses and medical people responding to it. So I highly recommend it. It's only about 45 minutes. If you have Netflix or you know how to watch something like that, I highly recommend it. I didn't put this on here too, but recently, I don't know if you are familiar with YouTube, but Channel 5 with Andrew Callahan, they did a fantastic video on safe use spaces and the drug addiction in San Francisco. If you are interested in what safe use spaces and like safe use education and what I'm talking about, I would recommend watching it. So that's what I have to say about opiates. All right. It's tough. It's a challenging situation. But what our job is to keep them alive for a day so they get the chance to make a better decision for themselves tomorrow. It's tough. You're going to see it if you work in this state. And the other thing I always just like to say is that everybody here, everyone listening to me right now, myself included, we are just one misused opiate prescription away from being a statistic like this. Nobody is exempt. This happened legally. And we do not have the right to judge anybody. If you think you're not going to be able to do that, don't be an EMS. I haven't heard of Soft White Underbelly, Kiara. I'm going to check them out. That's cool. Yeah. There's also been a lot of that kind of stuff too, like people doing some really good outreach, some people doing some really poor outreach too. But it's always inspiring to see when people are actually trying to shed some light on this issue, because it's very, very simple to brush it off as less than me because addicted. All right. We got half an hour to go through some other altered mental status things. So let's keep going. At any time, if you guys want to reach out or talk to me about anything due to opioid overdoses or opiates, please let me know. I'm sorry, I forgot to mention the names in red on that chart that I said of who are drug addicts. Those are the people in my family who have struggled with opiate or drug addiction. Happy to chat. Moving on to strokes, however. So, strokes. This is essentially the heart attack of the brain. I joke that it's a brain attack. It's essentially the same thing happening in the brain that happens to the heart. There's a blockage of blood, and it's not allowing it to get to someone's brain. So most of the time, what we're going to see is altered mental status and somebody who's having a stroke, but we're also likely to see weakness or complete paralysis on either one or both sides of the body, and difficulty speaking, which we call aphasia. So those are the three main signs However, you can see from this chart there just can be a whole bunch. Like it can range from possible seizures to like inability to control someone's bladder or bowels, and then also including the altered mental status, weakness, and difficulty speaking. Now, aphasia is kind of just like a fancy word, so I just wanted to give you an example. So what we're looking for is somebody having trouble speaking, but in very specific ways. It's not just going to be like messing up words per se. It's going to be very, very specific because we're seeing a part of the brain ceasing to function. So there's two types, non-fluent and fluent. All right, I'm going to show you non-fluent first.
Can you tell us your name?
Mike Caputo.
And Mike, when was your stroke?
I was 7 years ago.
Okay.
And
what did you used to do?
Worked Autodesk, seven sales, and worldwide, and very good. Yeah.
Okay. And who are you looking at over there when you turn your head?
That's my wife.
Okay. And what?
So right away you can see that Mike, he's doing okay understanding what this woman is asking him, but he's having a hard time actually finding the words. He said his stroke was 7 years ago, so he's had a lot of practice. But this is what we're looking for too. Somebody who's having hard times speaking, right? They can understand okay, but it's like a real struggle for them to find the right words, right? That's why it's called non-fluent. It's like somebody stumbling over the words, trying to find the correct one. Now, fluent aphasia is a little bit different. Now, I love Byron. Byron's fun.
Hi, Byron. How are you?
I'm happy. Are you pretty? You look good.
What are you doing today?
We stayed with the water over here at the moment and talked with the people for them over there. They're diving for them at the moment. They'll save in the moment. He'll have water very soon for him. With luck, for him.
So we're on a cruise and we're about to
We
get to
will
Juneau.
store it right here and they'll save their hands right there for them.
And what were we just doing with the iPad?
Right at the moment, they don't show a darn thing.
With the iPad.
So, pretty clearly different between Mike and Byron here, because Byron is not having trouble at all just like rattling off words, but he's having trouble understanding what she's saying, and when he's saying things, it's just not the correct words. So that's why we call it fluent. He's not having trouble speaking, but he's having trouble making sense, right? So that's what we're looking for. Any sign of like difficulty speaking, that's a danger zone. So some of the important things that we want to know is essentially when the last time they were seen normal was. Outside of like the normal things we're going to worry about is, are they breathing? Can they breathe? Do they have a pulse? But it's like, when were they last time seen normal? Because when somebody's having a stroke, the longer they're experiencing symptoms, the longer their brain is without oxygen essentially. So the more and more brain tissue is dying. So if I was with my grandmother last night for dinner and I like saw her at 8 p.m., I left, I came back 10 minutes later and she was acting weird, I would say that the stroke probably started between 8 and 8:10 p.m. Because I was with her all evening, I left for 10 minutes, and only in those 10 minutes did she start acting strange. But if I was with my grandmother, I saw her at 8 p.m., I came back the next morning or 2 days later, and now she's experiencing stroke-like symptoms, I could only say that she may have been stroking for 2 days, right? We have no idea. So getting the last time they were seen normal is actually really important. It's gonna like differ what kind of care they get at the hospital. And essentially, that's our first goal. And we really want to do an assessment to verify or just to increase our suspicion if they're having a stroke. So we're just going to watch one little section of this fun song.
Jenny and her grandma May on started to sway. Grandma sounded strange when she spoke, and Jenny had to ask, what if my grandma's having a stroke? I think I better act fast. I think I better act fast. Does her face look a little bit uneven? Does one arm drift down? Is her speech coming out kind of strangely? Then it's time to call 911.
I'm not going to make you watch the whole thing. I always showed the whole thing in my EMT class, and it's been stuck in my head for 10 years. So the other thing about this is that that time for us, it's no longer 911 unless you're like by yourself, right? And you stumble upon this. If we're like on an ambulance, that T is like time last seen normal. If you're on an ambulance and you're driving someone to the hospital and you call 911, bad day. All right. So this is our stroke assessment. We're going to look for any facial drooping. We're going to ask them to smile, essentially. We're going to see if their arms droop at all, drift, showing that they're paralyzed or weak. We're going to assess their speech. And if any of those three things is abnormal, they're having a stroke. And we're going to record the last time we've seen normal. We're going to get them going to the hospital as soon as we can. All right, so we always assess the face, the arm, the speech, and then time last seen normal. So this is how we do it. I will always go, hey, give me a big smile, show me all your teeth. Just like this. Yep, because then if we see something like this, right, then it's not good. We can see that they're having a stroke. Their face is drooping. Next, I'm going to have them, with their eyes open, hold their arms out in front of them, and then close their eyes. And what we're looking for is something like this. Right? Because somebody whose eyes are open might be able to compensate, like for a weak side, but if their eyes are closed, it's gonna drift. And it also might look like this. You're gonna say, okay, put your arms out in front of you. And you're gonna say, okay, you're having a stroke. Right? So any sort of weakness or normal function on one side compared to the other, it's a stroke. And then to assess speech, have them repeat like a well-known phrase after you. So usually I would pick like, repeat after me. It's always sunny in Philadelphia. Or you can't teach an old dog new tricks. And you're looking for things like Byron and Mike. So if they're like, it's always sunny in downtown Detroit, Philadelphia, right? You're going to say, that's not what I said. That's not right. Or if they're like, you can't dog, you can't teach tricks. Right? If something like that, you're going to say, oh, okay, that's wrong. Right? So in that case, bad time. It's kind of out of the scope of practice for even me as an advanced EMT to do anything. Somebody having a stroke needs an operating room. They need to get to the hospital as soon as possible. We're not going to be able to help them that much. We need to get them where they need to go. All right. The next altered mental status thing is seizures. Now, forgive me if I move kind of quickly through this. We do have a little bit to cover, and we got like 20 minutes to do it. If we don't get through by 8:30, I will have you guys leave. I will finish chatting, and you can finish it off in the video, okay? So seizures are really interesting. They are a sudden and temporary overload of the brain function. There's multiple different types, but essentially the one that we're really looking out for is like the classic grand mal seizure, while somebody has like uncontrollable body movements on the ground and they're unresponsive. That is called the big bad or the grand mal seizure. These other kinds are definitely possible. However, it's less likely we're called for like an ambulance emergency with these. It's probably going to be more of like something they discover throughout their life because they're not like full body seizures. Like a focal seizure might just like affect one part of the body. Absent seizures are really quick, like loss of consciousness for like a couple seconds in kids, and it's usually just like fixed with medication. And then complex partial are just very rare seizures. The ones that we see the most are generalized or grand mal, because it's when both hemispheres of the brain are overloaded. Now, when somebody experiences a seizure, we're likely going to see them go through a stage, like a pathway of it. Oftentimes, somebody who's about to have a seizure, especially if they have a condition like epilepsy, they'll experience what we call like an aura. So they might see something, they might taste something, smell something, they might get a certain wash of a feeling, and that actually will tell them they're about to have a seizure. And that's what seizure dogs, like service dogs who are trained to pick up on seizures, will actually recognize, is they start to sense an aura. They sense the seizure coming on, and they can tell their person to like lay down and get in a safe situation. Now, the next stage after that is called tonic. This is where the patient will just like all of their muscles will stiffen, they'll extend, and they'll stretch. And oftentimes they'll make a loud noise because the air is getting pressed out of their lungs. And then from there, they will go into that convulsion stage where all of their muscles are twitching all throughout their body. And that should last for only about 2 minutes. A standard seizure won't last longer than 2 minutes. If it starts getting longer than 2 minutes, that starts becoming really dangerous. And then another really important part about seizures is how the person acts after they wake up. If it's a true seizure, they will be altered for maybe 15 minutes to an hour afterwards. This is called a post-ictal stage. Whereas if somebody just faints, they're going to wake up and be pretty back to normal within about 10 seconds. Somebody who has a seizure can be really altered for a while. All right, so that's a pretty telltale sign that somebody had a seizure versus fainted. So one of the other things we want to know is how long have they been seizing and how often. So if we are showing up and we witness the first seizure, we want to time it, right? If it lasts anything longer than 2 minutes, we should be getting worried. If one seizure lasts longer than 5 minutes, or they have multiple seizures in 5 minutes, this is something called status epilepticus, and this is a true life threat that we need like a paramedic to come fix. They need drugs right away, or they need to get to the hospital. All right, so that's one of our main priorities, is time the seizures, and if they have another one, that's bad. Make sure you've got extra help coming. We want to protect their airway, right? Sometimes when people are seizing, they can drool a lot or vomit or maybe even bite their tongue and bleed. So we want to make sure that they're on their side so that any liquid that's in their mouth is draining out, not down. And the last thing we want to do is restrain them. We do not want to forcefully hold them down and fight against their seizure. That will hurt them, and that could hurt you. We want to let them seize, but we want to protect their head. So we might put a pillow between their head and the floor and protect them from any sharp things around them. We're going to move stuff away from them. We can roll them on their side, but we don't want to restrain them. And definitely do not put anything in their mouth, all right? That used to be something that was taught, was like, if somebody's having a seizure, like take a wallet and put it in between their teeth so they don't bite their tongue off. It's valid, like they do use bite blocks up at the hospital, but people just started putting whatever they could in people's mouths who were seizing just because they heard if someone's seizing, put something in their mouth, right? And it's just bad. We just don't do that. So just let them seize, time that seizure, and protect their mouth. Once they've stopped seizing, get a good head-to-toe assessment. Make sure you didn't see any like injuries, drug signs, or whatever. And then if you can, get a good medical history. See if they take medications or whatever. Main things for us, time it. If it lasts longer than 5 minutes or they have more than one seizure in 5 minutes, make sure that a paramedic is on the way or you are already on the way to the hospital. Now, I like to include syncope or just like fainting next to seizures because fainting is pretty common and oftentimes confused with seizures. When somebody faints, it's just like a really quick drop in their blood pressure, usually just due to like some weird thing happening. I mean, like getting scared, getting surprised, standing up too quickly, all the times that people faint. It's not really like a dangerous thing unless someone's doing it constantly. That would make me worried something's going on. But if somebody faints every so often, that's pretty normal. And really the main danger rests in like where they land when they faint. If they're driving a car, if they're at the top of the stairs, whatever it is. People oftentimes confuse seizures and fainting. But again, the main thing here is if someone fainted, they might be moving around, their arms might be out a little bit, but seizures will be rhythmic jerking, like really going, and they will last longer. Somebody who faints will wake up in 30 seconds. Somebody who has a seizure will not be normal for 15 minutes or so. All right, I think this is our last section.
diabetes.
So Wilford Brimley Cat. All right, so diabetes. This is another relatively common emergency that you might see, is somebody having low blood sugar. Now, diabetes is a condition where somebody's body doesn't produce enough insulin, or the insulin that they do produce doesn't work well enough to like bring sugar into their cells. And there are two types. Really, type 1 means that you were born with this condition and you oftentimes will figure this out in childhood or adolescence. And that's where the pancreas, the organ itself, just doesn't work as well. Whereas type 2 is a condition that somebody develops over a long period of time, where they eat a lot of sugar and essentially their pancreas burns out. So the insulin that they do produce isn't effective in letting sugar into the cells. And we actually need sugar really heavily to function. It's one of the things that your brain burns a lot of. That's why we eat. We need sugar in our blood. But if we can't get it into our cells with insulin, it either will mean that we don't get enough into ourselves and our body can't function without sugar, or we get so much extra sugar floating around in ourselves that it leads to a lot of other issues. As like, your brain needs this glucose. If you've ever been hangry, like I have been hangry, right? Where if you don't get food and just everything pisses you off no matter what it is, that's a sign that your body needs sugar. You have a functioning pancreas. I mean, if you are not diabetic, you have a functioning pancreas, and so your body really needs to get that sugar into you, and you are seeing signs of low blood sugar. But if somebody doesn't have a functioning pancreas, they're going to start getting hangry, and then it's going to continue to get worse and worse as their blood pressure drops to the point where they might go unresponsive and into a coma, right? Low blood sugar, very severe emergency. So what we're going to hope is that we can get an EMT on scene to give us an assessment, to use a glucometer to check a physical level of someone's blood sugar. Now, this isn't going to be within our scope of practice, but it is something that you might help somebody set up. Like if you're working with an EMT, you might sterilize the finger or set up the glucometer. And you might also be reading like the level. So I wanted to give you the ranges. When it comes to hyperglycemia, anything over 120, this is what we consider hyper, but it's only really dangerous to have high blood sugar when it gets above 250. There isn't like an acute, like really quickly happening emergency when it comes to hyperglycemia. That takes like days to weeks to kick in, whereas hypoglycemia can take minutes, like hours before somebody is unresponsive and close to death. So our normal range is between 80 and 120. That's where we should all be sitting most of the time. If you eat a really big meal, it's probably going to go above 120, but with a functioning pancreas, you're going to bring that back down to normal pretty quickly. And then anything below 60, this is where we start to see dangerous signs and symptoms. People being altered, people going unresponsive, people going into comas. So this is a true emergency. And hypoglycemia, remember, hypo meaning low, glycemia meaning blood sugar, so not enough blood sugar. It's not really seen outside of diabetics. It's mostly going to be in the population of diabetics. Like it's really hard for somebody who isn't diabetic to go hypoglycemic. And by the time that we show up, they're going to be pretty altered. The interesting thing about hypoglycemia is that oftentimes it's confused with alcohol intoxication. Somebody with low blood sugar can be like pale and sweaty and be slurring their words and be stumbly, and they can be kind of agitated, and they honestly act drunk, like they act inebriated. So I have been to police stations in their holding cells for somebody who was publicly intoxicated, adamantly denying that they've been drinking, and we come in to check them out. I take a blood sugar and it says 30, and I'm like, sorry, officer, this guy's having a medical emergency, right? He's not drunk. We oftentimes do that. It's one of the things that's kind of confused. Now, this happens really quickly. So someone can go altered and then progress into like severe unresponsiveness. They can even have seizures and fall into a coma and stop breathing. We need to intervene very quickly. Now, what you're able to do is give somebody a sandwich if they're able to swallow and comprehend. If you show up and somebody is a diabetic, or you like somebody has a blood sugar of 75 or whatever like that, you can give them a cup of orange juice give them a sandwich, and hang out with them for a little bit of time to make sure that they feel better. However, for you, I would say that call and make sure that you have at least an EMT on the way or advanced EMT, because if somebody is conscious at first, but while you're like trying to help them get them some food, they pass out, you're not going to be able to like give them anything into their stomach, right? You can't just shove a PB&J down their throat and expect it to work. These people need like medication. So at the basic EMT level, if somebody's still awake and able to swallow, within our medical protocols, you want to know what drug I give them? Vermont pure maple syrup. I'm not kidding. It's in our medical protocol book. We have 15-gram tubes of Vermont pure maple syrup. If somebody has low blood sugar, we give them 15 grams if they're able to swallow. Now, if they're not able to swallow, they're unresponsive, we, like an advanced EMT or paramedic, will start an IV and give them sugar in their veins. That usually works very well. But that's the point. So it's like if somebody can still swallow, we want to give them something that they can chew and eat and just like naturally bring their blood sugar up. But if they're unconscious, then we're not going to be able to do that. All right. And look at that, guys. I did it. Still finished with 9 minutes left. Thank you.